A continuación, le damos otra vez la bienvenida al Dr. Sullivan, esta vez con su conferencia The Worldwide Prevalence of COPD, la prevalencia de la enfermedad pulmonar obstructiva crónica alrededor del mundo.
También. So thank you. It seems like we met just a little bit ago. I'm on the clock again, and we're going to move forward. This subject is really about reviewing the prevalence of COPD around the world, and certainly in some certain areas where there's some difficulty. And in the process of this subject, we'll say a little bit about review of what's going on in the diagnosis, but most of what we want to look at is how much of this is going on around the world. You'd be very surprised at the numbers. Again, you saw the man in the shadow before. It's me. And as I said, I'm happy to be back up. And we want to look at the prevalence of chronic obstructive lung disease or pulmonary disease, or EPOC, as you call it. And we'll have quite a few things that we're going to talk about, but let's get right into the subject matter. I know that probably all in this room are aware that COPD is characterized by this preventable and treatable disease, and it's characterized by severe, persistent airflow limitation. We know it's chronic, it's progressive, and it's associated with chronic inflammatory response in the airways and the lungs, usually to noxious particles or gases. The real problem with COPD is comorbid conditions that exist with it, and there are many. Cardiac, blood pressure that are involved with this, and it contributes certainly to the overall morbidity level and the severity in patients. I would like to refer all of the students, in case you have not accessed this, the GOLD, yes, we'll just use this, the GOLD guidelines that I have down, you referenced down here. Brand new guidelines came out on December 30th, 2011. So if you have not visited the website on the Global Initiative Chronic Obstructive Lung Disease, or GOLD as it is known, please do so, because there are some new points that you want to reference, particularly for those of you that are new to this. As you know, in the past, GOLD has suggested that diagnosis be confirmed by spirometry. Well, now the new guidelines require that it's a must. It must be confirmed by spirometry. And you can use basic spirometry, the fixed ratio after a bronchodilator has been administered, FEV1 compared to forced vital capacity. And you can see that we're suggesting there are a number of grades, as they're referred to now, instead of stages, grade 1, 2, 3, and 4. There is actually a fifth, which is actually grade 0, which is not on here, but this is one which there are not symptoms, I should say there's nothing that is found on spirometry that would indicate a disease process. But they do have some obstruction and trouble breathing and so on. Now, grade 1, 2, 3, and 4, all the way up to very severe, as I think you're familiar with, this FEV1 measurement. And then now, as I said, gold standards insist that spirometry be done. We're going to spend a little time talking about what it's about. Again, I think we're comfortable with this. Tobacco smoke is the most important intervention in management. You will learn that from anybody unless they smoke. Occupational dust and chemicals, indoor and outdoor pollution. This applies in some countries where, in some areas where the indoor pollution is exaggerated by cooking smoke and various other noxious materials. I want to spend just a little time about cigarette smoking, because in the United States it's dropped off dramatically. In the United States, 90% of chronic bronchitis is related to tobacco smoke exposure. There is, as we know, a dose relationship. The smokers are more likely to die than non-smokers of COPD. Now, that's not just conjecture. I think you'll get copies of all these slides, and I would like to have you take a look at these references in here. This is American Review of Respiratory Critical Care Medicine, 1995, was a breakthrough study. And most of this stuff now that we think of as second nature took a long time to develop. Chronic inflammation, present in the airways and the parenchyma of ex-smokers. I know that when they say when you quit, it goes away. Well, it doesn't totally go away, and it takes a long time. Certainly, in this prevalence discussion, passive exposure, secondhand smoke, side stream smoke as it's known, is an important component. We also know, with the emerging evidence that's coming out on the relationship between asthma, early asthma, and chronic obstructive pulmonary disease, that acute inflammatory triggers and hyperactive airways, this cigarette smoke, tobacco smoke, can serve as a trigger for that. And much of the research that began on that was with asthmatic children who were in the home of parents who smoked. And so, even the unborn is affected, as we know, and the loss of lung function that results in reduced FEV1s, that loss of lung function can continue in ex-smokers that have already got established COPD because it's a chronic disease process. Risk factors, there are many. And as we look at them now, it's a spectrum. We used to think of COPD as just one brand of cat, and it's not. It has a lot of things that can contribute to it, including genetic susceptibility, lung growth and development in preemies and things like that. Alpha-1 antitrypsin, which we've talked about here just for a moment. Okay. It's not as rare as people think. Every 1 in every 1,600 births, the AAT gene was identified some time back, which affects the serum level of alpha-1, and it can lead to emphysema because of the breakdown of the parenchyma in the lung, but also it severely affects, the liver and causes disease. Again, I refer you to American Journal of Respiratory Critical Care. Take a look at these things when you have more time, but the references are certainly there that this is, in fact, a process that we have to concern ourselves with. These are the individuals where emphysema can appear before the age of 45, and with or without risk factors, and there is usually a family history that develops. And again, continuing studies show this. The worldwide impact, the prevalence of the disease is tremendous. And we have some data here that we can look at to give you an idea, including some data from South America. COPD does remain a major public health problem, and it will for many, many, many years to come. In 2020, it was projected to rank 5th worldwide among the burden of disease. The burden of disease includes concepts such as how many days at work were missed, how much money was lost to the national economy, to the family economy, as well as the clinical problems that are associated with it. And I think it's significant that the World Bank and the World Health Organization have teamed up for some of these reviews to give us not only the economic and social impact, but the clinical disease process as well. Arguably, COPD now is recognized as the 4th leading cause of death in the world. In the United States, it has probably already assumed the number 3 position, and in some other countries in the world. So if you consult the World Health Organization, 3rd or 4th, and this is far ahead, it's an accelerated pace of what was projected in 1990 and in the year 2000. It represents a global health problem, and remember, the main culprit is side stream and direct tobacco smoke, not the only one. It is a disease that is both preventable and treatable. Major cause of morbidity and mortality throughout the world. I'm going to show you some slides from China, as well as from here in South America. Patients in the family can suffer with this disease for many, many years. You know that, I know. We're the ones that are firsthand at the bedside to take care of these individuals, and we know how debilitating COPD is and how expensive it is to treat. Premature death, we're going to take a look at that and a little data from COPD or its complications are tremendously effective. In the coming decades, this burden is suggested to increase, and that will be because many of us are living longer, and many of the risk factors have longer time to develop. So the exposure to COPD and its risk factors and the aging population of global humanity is helping to express the long-term effects of this disease. It varies across countries, regions of countries, and even within different groups. And often, as I said, the prevalence of the disease is directly related to tobacco smoking, and in some countries, as I mentioned, to outdoor and even indoor air pollution. Surprisingly, most national data, if you consult studies for your own country, for the United States, for China, you'll find that less than 6% of the adult population even knows they have COPD. And even though they may have visited a doctor, and they may have had spirometry studies, they don't even know because of problems. There's widespread under-recognition and under-diagnosis of COPD. When we look at some data, it comes out, it jumps right out at us, because we know about this. We know the effects and who it affects. But this data helps, in a scientific way, bring this forward. A systematic review and meta-analysis of studies across 28 countries between the years of 1990 and 2004, and it's referenced here in the global burden of COPD. This was a study which was a real breakthrough study, this meta-analysis. There were 128 good studies that were combined in this review. And it shows that the prevalence of COPD is appreciably higher in smokers and ex-smokers than in non-smokers. It's higher for people over the age of 40 and higher in men than women. Presumably because more men used to smoke than women, but now In the United States, for example, the women have caught up with and passed the men in terms of the incidence of smoking cigarettes. Now, this seems like common sense to you and I. We know this. We've known it for many years. We observe it. But this is scientific evidence to help convince policymakers in different countries that things have to change, to help convince the World Health Organization that things have to change, to help convince individuals where there's a high incidence that things have to change. Those who are students of public health know that change does not occur unless there's a real scientific basis for it. Now we are beginning to have some very strong data to bring that about. This is a study, I'll show you a slide shortly, about the Latin American project for investigation of obstructive lung disease, and conducted in 5 cities, different countries in your area. Found a higher prevalence of COPD with increase in age. We would assume that, because you know the normal aging process of the lung actually produces changes that are emphysematous in nature, like the disease process, the breakdown of the parenchyma. So it's not a surprise, but there is scientific evidence to look at this. The highest prevalence among those over the age of 60. The study also identified a higher prevalence in males than in females. It's interesting to note that the burden of obstructive lung disease, or BOLD, this study found a substantial prevalence, somewhere between 3 and 11% of COPD in individuals who never smoke. This is an area that's under intense research at this time. Why do some people who don't smoke get emphysema? I'm not talking about antitrypsin, alpha-1 antitrypsin. People that have apparently no other risk factors come down with the disease process. So this is an area where we can learn quite a bit. The morbidity obviously increases with age. The patients affected by other comorbid conditions, as I mentioned earlier, cardiovascular disease, musculoskeletal impairment, diabetes, blood pressure swings, all of this is what happens through the disease process, and makes the condition very difficult to manage, very expensive to manage. Yesterday, the very first speaker in this Congress talked about some of the disease process and the expense. For 5%, you remember the slide from yesterday morning? 5% of the patients used up 50% of the intensive care unit resources. Billions of dollars worldwide, billions. So, the global prevalence is increasing, and under recognition and under diagnosis, as we mentioned, clearly affects the accuracy of mortality data. Many death certificates, and the death is actually due to a pulmonary disease. They're not even noted on the death certificate, because it takes some real public health awareness, disease process awareness, to investigate this. So, many times, COPD may be the primary cause of death, and it's not even listed or omitted entirely from the death certificate. Now we look at some surprising numbers.